Okay, thanks everybody. I think there's a few more coming in, but we'll make a start so that we keep to time. So I hope you all had a lovely lunch and got to speak to some more people. The next session takes us right through to 3:15. So this is around licensing, licensure and assessment. And just to provide a little bit of context with some of the discussions that I've been having with colleagues around the world recently, is our own statutory membership exam, I know, is getting really challenging because there's ever-increasing numbers and they increase every year and not by a little amount. We're looking on a 40% increase every year. So whilst that's a great thing because we want the vets and it's really great to see the increasing global movement of vets, I think there are challenges around implementing exams and particularly performance assessments in that context. And I know colleagues in Australia, Canada and the US are in the same position. So it felt really useful to have a session focusing on that and try and learn from different experiences and potentially discuss some solutions as well. So we have 3 speakers in this session. So we have Professor Suzanne Chamberlain. We have Lindsay Sproul and Amy Farmer, and there was a slight amendment to the programme. So the final session with Amy will be a little bit shorter, and then we're actually going to move to a panel discussion and invite John Norsini back as well, so that we can discuss some of the issues around all things licensure. So without further ado, I'm going to welcome Suzanne to the stage. Suzanne's from the GMC and is in charge of their licensing assessment and is going to tell us all about their recent experiences. Thanks, Suzanne.
Thanks very much, Linda, and thank you so much for the invite to this fabulous event. It's been great to already just hear some of the discussions that you've been having today so far, and to really draw on those parallels between medicine and veterinary medicine. 2 groups of highly professional, specialised professionals, so much in common and all dedicating so much time to some of the same endeavours. So it would be really useful, I feel, to sort of make some connections in the UK and perhaps internationally. So I'm very grateful to be able to come and talk to you today about how we assess doctors for UK practice and about the spectrum of assessment through undergraduate through to postgraduate, and that includes a licensing assessment and includes our revalidation process. So these are the things that I will cover today, and this will be a fairly quick gallop through that trajectory of training, education and assessment for doctors in the UK. I really want to get on to that medical licensing assessment and revalidation. Before finishing with just an insight into the GMC's ambition to eliminate discrimination and disadvantage in education and training. Assessment gives us the insight into that discrimination and disadvantage and about the award gap between different groups of candidates. So it's a really big theme for the GMC. So for those of you who are not aware of the General Medical Council, our role is set out in the Medical Act, and it is to protect, promote and maintain the health, safety and well-being of the public, to promote and maintain public confidence, and to maintain professional standards and conduct. So all of the work that we do in the General Medical Council, and we're a fairly big organisation, is wrapped around those standards that we set for the medical profession. And our areas of work encompass education, which also includes training and assessment across undergraduate and postgraduate, although our powers are slightly different for undergraduate and postgraduate. Maintaining the medical register, the revalidation process, and also fitness to practice. So this is the process whereby we deal with complaints and in those very serious cases withdraw licenses to practice. Very rare events. So our register, just to give you a feel for scale, we have over 300,000 doctors holding a licence to practice. For the first time, the gender split has transitioned in favour of female practicing doctors. We have nearly 80,000 trainee doctors on the register, and about 42% of our registrants are graduated overseas. That number has increased significantly in recent years. So what does it mean to be a doctor? And there will be an awful lot of parallels between medicine and veterinary medicine. This is based on some research that GMC did back in 2018, because prior to COVID, an annual survey was showing that actually there was a state of unease among doctors. There were doctors leaving practice, there were doctors taking extended breaks from practice and time out of training, and so there was this general unease and creeping dissatisfaction. And so we look to explore, what does it mean to be a doctor, and also what are the factors that influence satisfaction with the role. And as I say, I'm sure some of these will be familiar to you, but the satisfaction and the dissatisfaction correlated quite strongly with some particular features about practice, the time spent working, the contact with patients, working in multidisciplinary teams, seen as a positive, obviously, locum and shift work, how much opportunity doctors had to suggest innovation in the workplace, how much autonomy they had, and also the administration burden. Unfortunately, I missed Lambert's talk this morning from a train delay, but I was saying over lunch, one of the most impactful things I've learnt myself about AI is that we've aimed very high in terms of what AI can do for us, and in medicine we're sort of exploring, can AI help diagnose? Can AI help come up with management plans and treatment plans? When actually it's the administration burden that AI can potentially help with, and it's the administration burden that has a massive impact on satisfaction with work. So, just an interesting opportunities for AI in that space. So the career journey of a doctor, medical school tends to be 5 years, but can be 4 years for graduate entry programs, up to 6 years. And on completion of medical school, the newly graduated doctor will register with the GMC on our provisional register. So this is for supervised practice. They then go into 2 years of foundation training, where they will rotate around clinical specialties and gain that hands-on, real-world experience dealing with patients day in, day out. At the end of completion of year 1, they then progress to the full medical register that permits them towards unsupervised practice. On completion of that 2 years of foundation training, they then move into either non-training posts or become a locally employed doctor, or they move into specialty training, into a training post. And that can take, the duration of that can be between 3 and 8 years, depending on the specialty that they are pursuing. And then at the end of their specialty training, they will get that certificate of completion of training. And this is a full but not completely exhaustive list of the roles that are available in the NHS to doctors who've completed their CCT. Obviously, doctors, like veterinarians, you will be very, very experienced with assessment. There are multiple opportunities for low stakes and high stakes assessment throughout that learning journey and through that journey to qualification and on the register. And medical assessment comprises many different methods. Assessment goes through fashions, through cycles. Some of these have become less in favour, some of these are more in favour. the big bang, high stakes assessments still tend to look the same. They still tend to be the knowledge exam that comprises the multiple choice, single best answer, best of 5 options, clinically applied STEM and scenario with that sort of diagnosis or management question. And there tends to be a lot of OSCEs. So we use OSCEs to assess those clinical and professional skills. And the OSCE is a very standardised exam, as I'm sure you're aware, where the candidates move along the stations, all candidates seen by the same examiner over a particular clinical task. One of the interesting trends in medical education and assessment has been a bit of a shift away from the psychometrics and the statistical and the standardised towards more professional judgment, and using that, that real professional clinical expertise to make a holistic judgment about somebody's readiness to perform, readiness for practice, rather than purely relying on the data and the statistics. I mean, there's probably a halfway house somewhere where, the statistics plus the professional judgment is the optimum. But as I say, it moves through cycles, it goes through some fashions, and things like true-false items and extended matching are out of fashion at the moment. People have moved away from those. And there's a real recognition that multiple choice, again, is not completely satisfactory. It's easy from a measurement perspective. You can cover an awful lot of content with a multiple choice question paper, but there is a move towards short answer questions, so really getting at understanding rather than offering that list of options to choose from. So the GMC has various roles in assessment. We have recently opened our register to anaesthesia associates and physician associates, and so there are new assessments that the GMC is involved with there. But today I'm just going to focus on the medical licensing assessment. So there are 2 versions of that, one for UK students and one for international medical graduates, which we call PLAB. It's a 2-part test that is run for international doctors who qualified overseas wishing to gain a UK licence to practice. I'll also go through the revalidation process, and then, as I mentioned, just end with a few pointers on the GMC's fairer training cultures work, which is all about eliminating discrimination, disadvantage. So our medical licensing assessment, this has been 10 years in the making, not a quick process, and in fact GMC Council registered a comment about bringing in a national licensing assessment back in 1859. That was the very first mention. So this has been a very, very long time coming. And there were several drivers. So, why now? As we've been talking about it for such a long time. And that was because there's been a massive expansion of undergraduate medical education. The number of medical schools was static for a long, long time, and in recent years it has increased. And there are currently 44 medical schools in the UK, across the 4 countries of the UK, and there are more coming online all the time. Obviously there are more student places. That's puts a lot of pressure for those placements and so on. So a highly politicised arena, the growing number of medical graduates, and the chart there shows the growing numbers of international doctors who were taking our PLAB exam. So back in 2014, it was around about 3,500 candidates per year that were going through our PLAB exam, up to a peak of 2024. That went up to about 22,000. Just in the last year, we have actually seen a drop in the number of international medical graduates seeking that UK licence to practice. We don't actually understand the reasons why, but it really has gone a bit of a cliff edge. So that's a bit of a concern for us. Obviously, it's an income stream, so we need to understand what's happening there. But with that growing number of international doctors, that was one of the drivers for the medical licensing assessment. There was also research that showed us across all these medical schools that actually they were using different methods at finals, and more importantly, they were actually applying different standards. So your primary medical qualification from one medical school is not necessarily equivalent to a primary medical qualification from another medical school. And also, we wanted to understand and address the award gaps. So medicine, same as veterinary medicine, highly competitive. There are medical schools that are really focused on widening participation. We know that there are some candidates who come from non-traditional backgrounds, and we know that actually there are real differences in outcomes and performance for certain groups of candidates. An assessment gives us a window into that. It allows us to use that data, standardised data, to understand where those award gaps are, and once you understand where they are, then you can start addressing them, bringing in new initiatives to support students. So those were all our drivers. This was our aim and the intended benefits of bringing in the licensing assessment, and I think it's fair to say that assessment methods come and go, and assessment designs will come and go, but actually this is the touchstone for the medical licensing. This is set in stone. This is what it was set out to achieve. And it actually looks very simple, but it took us a long time to agree on this. You know, what is the aim here? We know that assessment can have multiple purposes, not only measuring ability and performance, but also rating teachers and rating your curriculum and so on. We were really clear that this had a singular aim. This was not about getting insight into the performance of medical schools and so on. Obviously, it tells us something about that, but all of that information is contextual. You can't compare a pass rate in one medical school with the pass rate in another medical school when one of them is a new medical school that has a real emphasis on widening participation, and the other one has a very traditional intake and just a completely different setup. So these were what we wanted to get out of the MLA and bringing it in for us, and this is what we refer to all the time. As I'm sure you can imagine, with quite a large population of stakeholders, the reason why it took 10 years is because there were a lot of voices that had to be consulted, and there were a lot of opinions about what it should be, what it should look like, what the purpose was, what the design should be. It was a really complex landscape. We did a public consultation. We worked very closely with lots of expert reference groups, and it was really challenging at times, actually. We came up with multiple proposals, and you sort of knock the edges off each proposal, and then you come up with a different proposal, and then that one gets knocked around. So it was a really complex thing to do. Where we started was not where we ended up. So we started with a very traditional two-part model, which is actually what we've got, but we were going to have a singular exam for UK students and international medical graduates, and it was going to be delivered by the GMC. And for multiple reasons that was not acceptable or palatable to stakeholders, so we came up with another design. So a lot of information on this slide, but this is the MLA in a nutshell. So bottom right here, all candidates do take a test that meets the same requirements and that draws from the same content, but they are not the same tests. So for UK students, they take an applied knowledge test, so the multiple choice paper, it was 2 papers of 200 items over 4 hours. That is centrally set and coordinated by the Medical Schools Council. So the GMC does not set this exam. We quality assure it. So we have requirements that this test has to meet. Evidence has to be provided to the GMC. We evaluate that evidence, but we don't actually put this test together and we don't deliver it to candidates. That's all done by the Medical Schools Council on behalf of all medical schools. And then the Clinical and Professional Skills Assessment, the CPSA, that is developed, designed and delivered locally. So every medical school is responsible for delivering their own CPSA, but again, it has to meet all of the GMC's requirements. They have to provide an awful lot of evidence to us that we evaluate alongside our expert associates, and then we respond to all of that evidence that we've had and make a decision about compliance, whether the evidence is compliant with our requirements. So UK students, as I say, they go through the 2-part MLA. and they do this as part of their medical degree. So passing the 2 parts is a requirement of the medical degree now, and is a requirement for provisional registration. The international medical graduates, they take the same exam as they've always done, the 2-part PLAB exam, but now that 2-part PLAB exam is also compliant with the same requirements as the MLA for undergraduate students. And passing that exam then leads to full registration for the IMGs. There are other routes to registration in the UK, but PLAB is the most common one. So there are equivalence routes and I can't remember what the other ones are. The equivalence, no, it's totally gone, sorry. But it's based on appropriate qualifications. So that is the MLA model. As I say, not where we expected to start. Oh, my button has stopped working. Could you move the slide on for me, please? Thank you. So I mentioned we've started an evaluation. So we're looking at a 2-phase evaluation over quite a long period of time, around about 10 years. But we're in phase 1 at the moment, which is just a 12-month period. And we're looking at the early benefit realisation. So what impact has the introduction of the MLA had on students and medical educators? So again, talking to lots of stakeholders about their experiences and perceptions. Move on, thanks. Can you move on for me? Oh, there we go. Thank you. So, moving on to revalidation. So this is another large initiative that the GMC has brought in within the last 20 years. Bringing in these interventions on a national scale is really complex, as I say, lots of voices, lots of opinions, and revalidation is exactly the same as the MLA in that sense. So the first priority of the revalidation process is patient safety, and to ensure patients are confident that clinicians are up to date and fit to practice. Based on the values of GMC Good Medical Practice, so that's the foundation for that, every revalidation is measured against those standards set out there. And importantly, it ensures that all clinicians have equal access to appraisals and development opportunities, which was not the case prior to revalidation being brought in. It was implemented in 2012, and by the 2017, the majority of clinicians had been through it, and it's a 5-yearly cycle based on 5 annual appraisals. So the evidence that's used for revalidation comprises quality improvement activities, CPD, significant events, feedback from colleagues and patients, and compliments and complaints. Also descriptions of roles that have been held in the past 5 years, personal development plans, statement and health statement. So it's very comprehensive, a really big portfolio of evidence gathered over 5 years that is based on those 5 annual appraisals. The process is very much based in the workplace, so this is the relationship between the doctor and their appraiser, who will be somebody that they know. The appraiser will look through all of that evidence, evaluate it, and make a recommendation to the GMC. So it's very much led by that workplace supervisor, and then the GMC will validate that recommendation that's been made from the workplace supervisor. So just to finish, as I mentioned, the GMC is really keen to understand disadvantage and discrimination, and we set a target to eliminate it by 2031. This is a really ambitious target, of course, but we set the bar high in order to drive improvement. And we have a strategy that we put in place in order to support that work. Achievements so far, we've managed to enhance data collection and analysis. That's an absolute keystone to understanding discrimination and disadvantage in education and training. We've input new support initiatives and actually been able to evaluate the performance of those initiatives, and the research has been really positive there, that showed that underperforming cohorts can improve their performance with that targeted support, and that's something we're exploring further. And we also host an awful lot of networking events and education events to support colleagues in the workplaces so that they're aware of the work that we're doing in this space. We also use that data to track the impact, as I say. We're managing to gather data, and we can keep an eye on that progress. We've been monitoring that since 2019, and these are just sample charts, but they show the difference between white candidates and ethnic minority candidates, and also the UK students and the graduates from overseas as well. So these are some of the things, some of the actual tangible things that we've been doing to support that work. We have provided enhanced training for trainers, the exam prep course and materials and resources, ensuring that recruitment processes are fair and unbiased. Improving the quality of feedback is really important. Use of representative images in the item banks and the question papers, making sure that it's not just white skin that's represented in images, for example, mentoring schemes, monitoring outcomes, and interventions, and also making sure that there is diversity on all of those groups that are making decisions about candidates' performance and progression. Thank you very much, and welcome some questions.
Thank you, Suzanne. So we've got about 5 minutes for questions. There's one at the front here.
Thank you. That was really interesting. So I'm involved in undergraduate veterinary education, and we have about half of our graduates sit the North American licensure exam. Will you be planning with the doctors to link the school's accreditation to their pass rates in the licensure exam?
So we've just completed the first full year of the MLA. The results are provisional at the moment. What we found is that there is very little variation in medical school pass rates. The exam is purposely set at the level of being safe to practice, so it's not assessing for excellence. And because it's set at that level, it's that chronological knowledge that Ollie was talking about this morning. It's the core foundation, day one knowledge that you need to go into supervised practice. Actually, the pass rate is quite high, but yes, you're absolutely right. As a regulator, we will be monitoring the pass rates for medical schools, and if we find that there are medical schools where the pass rate is low, then we would be looking to understand that and provide support to that medical school. But so far, it doesn't seem to have materialised, but there could be all kinds of reasons for that.
I just have a question about your revalidation process. It's a discussion we have as well. What do you do with your doctors who have gone into senior management roles and are no longer seeing patients?
So they can maintain their licence. So I'm not quite sure what we do with those. In order to maintain their licence, there's still an obligation to have an appraisal every year. There would still be an obligation to go through the revalidation process, but obviously it won't be based on clinical evidence. It's still important that they gather that evidence from people that they're working closely with on a day-to-day basis. So yeah, it is an obligation of maintaining the licence that there will be an appraisal, but slightly different if they're not clinically facing. Yeah.
Any more questions? No, it's just a comment from me. I mean, I find this really interesting, Suzanne, as we've spoken. Our Vet Surgeons Act is even older than your Medical Act, 1966, and we are unable to have a UK licensing exam or revalidation, but we are sort of hoping for a new one very soon, and both to be able to introduce either of those things is on our wish list, shall we say. So thank you very much.
Thank you.
Okay, thank you.